the presentation. So I told you the PanIN is a non-palpable lesion and IPMN is a palpable lesion, and they have the criteria. The size is for PanIN it is less than 0.5 centimeter, whereas IPMN is more than 1 centimeter. Nowadays the sizes they take it in the radiology, because by the time we get the pancreas, we fix it, the size difference may be there from real to artifactual lesions. So they take the radiological size, and as I told you, PanIN is not visible. Microscopically, it shows only gastric foveolar type of epithelium, whereas IPMN can have 3 types of epithelium: gastric epithelium, intestinal epithelium, and pancreatico-biliary epithelium. Molecularly, GNAS is very, very important in the IPMN. This is one of the questions they ask in the exam. What will you do when you aspirate a cyst, and how will you process? Number 1, send it for cytology. Number 2, send it for amylase level. Number 3, send it for molecular change with GNAS. When GNAS is positive, it is IPMN. And here you can see 0.5, less than 0.5 and 1 centimeter. So what will happen if the lesion is between 0.5 to 1 centimeter? Give you a descriptive diagnosis with both as differential diagnosis. But when you see finger-like papillae, then it is incipient IPMN. Go for GNAS. When GNAS is positive, that confirms the diagnosis of IPMN. So PanIN again, microscopic, ductal connection, non-invasive. The lining epithelium can be flat or papillary, and architectural and cytological atypia may present, and they are mainly lined by gastric foveolar type of epithelium. Previously, PanIN is divided into 1A, 1B, 2, and 3, but now we follow the two-tier system. I will show you the two-tier system. Normal, PanIN 1A, 1B, PAN2, PAN3. 1A, 1B, and PAN2, PanIN 2 are now low grade, and PanIN 3 is high grade. And this table gives the features, how you differentiate normal from low grade PanIN and high grade PanIN. Normal, the lining epithelium is flat, cuboidal in shape, no stratification, no atypia. This cribriform and comedo, I will just leave it because it is seen only in the high grade PanIN. Okay, so normal, flat, cuboidal cells, no stratification, no atypia. In the low grade, it can be flat or papillary. They are columnar. The cuboidal cells become columnar in PanIN. Stratification is present. Atypia is mild to moderate in low grade. Whereas in high grade, it is mainly papillary. The cells are again columnar. The cells are stratified. The atypia is very severe. And as I told before, the cribriforming and necrosis is very characteristic of high grade PanIN. You see the picture. So this is the two normal pancreatic ducts. This is more like intralobular duct, and this is interlobular. You can see flat lining epithelium, cuboidal cells without stratification or atypia. So this is normal. Here they become columnar. Okay, but there is no atypia. It looks normal, and focally it is stratified, and so this is PanIN low grade. Okay, so this is columnar cells, and look at these nuclei. They are mainly in the inner 1/3, are trying to go into middle 1/3. They are not in the upper 1/3, and all the nuclei are running in one direction. These 2 points are very, very important to differentiate low grade and high grade. In high grade dysplasia, the nuclei will reach the top of the cell, and there will be loss of polarity. I will show you in the pictures. And in addition to that, if you see cribriforming and comedo necrosis, it is high grade. So this is low grade. This is again columnar cells, slightly thrown into papillary folds, and the nuclei are again confined within the middle 1/3 of the stratification, and there is no comedo or cribriforming. and the polarity is maintained. Polarity means you draw a line all along the long axis of the cells, and all the nuclei will be traveling in one direction. That means the polarity is maintained. For example, take this cluster, and when you draw a line along the long axis, they will be parallel to each other. So that's what we call polarity is maintained. And to see the polarity, the nuclei has to be elongated. If the nuclei is round, we cannot assess the polarity. Unfortunately, many books are not mentioning that. They think it is understandable. Because when it is round nuclei, you can't draw a line along the long axis. There is no long axis for the round nucleus. So this is also low-grade columnar cells thrown into mild papillary folds. Stratification is there, and the nuclei are confined to the middle one-third of the cells. Here also the stratification, columnar cells, the nuclei are not touching. They are trying to come, but they are not touching the top of the cells. But the polarity is maintained. Look at here, all the nuclei are traveling in one direction. Look at here, all the nuclei are traveling in one direction. There is no cribriforming or comedonecrosis. Here you can see nice low grade. Probably this may be going into high grade, but it is still low grade because of maintenance of the polarity, and the nuclei are in the middle one-third. You can see here cribriforming in the low power itself. So this is high grade. And look at the nuclei reaching the top, high grade. And look at the loss of polarity. I will show you the loss of polarity. See, this nuclei runs like this. This nucleus is runs like this. This nucleus is running like this. All the nuclei are running in different directions. For simplicity, I used to tell the traffic in the national highway is polarity maintenance, whereas traffic in front of Chettinad Medical College or Ramchandra Medical College, polarity is lost because all the vehicles are running in different directions. Whereas in national highway, all the nuclei are running in the same direction. So this is high grade. IPMN, as I told before, more than 1 centimeter. It can be anatomically, it can be from the main duct or branch duct. Histologically, it is gastric, intestinal, and pancreatico-biliary. Here, see the duct, and see the lesion is connected with the duct, and it is visible more than 1 centimeter. So this is IPMN. Again, dysplasia, what I mentioned is again mentioned in this table. So normal, low-grade dysplasia, high-grade dysplasia, single layer, nuclear basal, mucin present, no mitosis, no apoptosis. Low-grade dysplasia, stratified, polarity is maintained, no cribriforming micropapillae or comedonecrosis, nuclei middle one-third, mucin is absent. Normal mucin is present in low grade and high grade. Mucin can be absent, or in low grade, mucin can be present. Macronucleoli, again high grade. Polarity is lost, cribriforming, nucleus reaching the upper third and seen at the apex of the cells, and macronucleoli, mitosis and apoptosis. This is high grade. Dysplasia, this table is good for any tubular organ. For example, stomach, small intestine, colon, bile duct. You can apply this criteria for all the tubular organs. It's a beautiful section from the duodenum. You can see the major duct filled with lesion more than 1 centimeter, palpable. So this is from the low power itself, it is IPMN. And when you see the lining epithelium, these are like gastric foveolar epithelium, and the nuclei are at the base, no cribriforming, no micropapillae, no comedonecrosis, and the polarity is maintained. So this is low grade gastric type of IPMN. Here you can see a lot of goblet cells, and they are arranged in villi. These are like intestinal type of IPMN, again low grade. Here the lining epithelium is more like pancreatico-biliary, and there is micropapillae, There is cribriforming and the nuclei are reaching the top and loss of polarity. Look at here. This nucleus is running in this direction. This nucleus is running in this direction. This nucleus in this direction. This nucleus in this direction. So loss of polarity. So this is IPMN pancreatic biliary type high grade. Again, low power view of IPMN high grade. Higher power view of IPMN higher grade. And remember, I told you any cystic benign lesion can have invasive carcinoma. This is a beautiful example. I have given the name of this beautiful pancreatic pathologist from University of Pittsburgh in the references. He takes very nice pictures. So this is a pancreatic, distal pancreatectomy. You can see the cystic lesion along with a more solid lesion here. And microscopically, you can see invasive carcinoma, poorly defined glands, the growth near the muscular vessels, and apposite glands and glands infiltrating the fat. These are all the features of pancreatic carcinoma, NOS. So pancreatic cancer. And the associated cyst shows IPMN with high-grade dysplasia. So both IPMN, PanIN, MCN, serous cystadenoma can be associated with cancers. So you have to take adequate sections, and if there is an area of a doubtful lesion in the gross specimen, you alumbate that area because we have to identify the tumors associated with the benign lesions. And we talk about perineural. This is a beautiful example of perineural and intraneural. And in the exam, there is one more mnemonic. Perineural invasion is seen in 3 P's: parotid, pancreas, and prostate. Please remember, parotid, pancreas, and prostate adenocarcinomas can have perineural invasion. This is a cystic lesion. You can see here connected with the major duct, and this is having a ATP1B1 BRCA fusion. So this classic of intraductal oncocytic papillary neoplasm, but you cannot diagnose it grossly. You have to look at the microscope. You can see the the low-grade dysplasia with the oncocytic cells that can be appreciated very nicely in the higher power. This is again low grade because they are not that much stratified, and all the nuclei are running in one direction. No comedonecrosis or no severe ATP. This is another intraductal lesion called as intraductal tubulopapillary neoplasm. This is a new terminology in this current WHO classification. This is also intraductal, but morphologically it shows tubular and papillary structures, and it is of high-grade dysplasia, and this totally lacks mucin. So when you see abundant mucin, low and high-grade dysplasia, papillary, comedo without comedo type necrosis, it is IPMN. Whereas ITPN can have minimal to none of mucin. Usually it is high-grade dysplasia. You see a lot of tubular structures, and comedo-like necrosis is very common. So this is a classic picture of ITPN. Okay, here you can see a lot of tubules, solid, non-mucinous. You don't see mucin at all. This is again the highest power. See the tubules, high-grade dysplasia. Here polarity you cannot assess because most of the nuclei are round. So this is ITPN. This is another cystic neoplasm and multiloculated filled with mucin. And another thing I forgot to mention, these are seen, the mucinous cystic neoplasm are seen only in females. Remember, I mentioned we see ovarian type of stroma, so it is seen only in females. And more importantly, no duct connection. See the ovarian type of stroma, mucinous epithelium. This will look like a mucinous cystadenoma of the ovary, but it is in the pancreas. And this is low grade. All cystic lesions, whatever we have seen, PanIN, IPMN or MCN, we have to see whether the dysplasia is there or not. And whenever there is dysplasia, we have to see whether it is low grade or high grade. When it is high grade, we have to see is there any adjacent carcinoma. Again, low grade MCN, you can see very nice ovarian type of stroma. And these ovarian type of stroma are nicely positive for progesterone receptors. And this is like a normal, and this is low grade dysplasia, and here it becomes high grade dysplasia. See the crib forming. See the nuclei coming to the top. Okay, look at the low grade. The nuclei are still in the middle 1/3. So this is a mucinous cystic neoplasm with the invasive carcinoma here. Look at the number of mitosis. This is another invasive carcinoma arising in a background of mucinous cystic neoplasm. So the main differential diagnosis is MCN and IPMN. This is very, very important because the prognosis is totally different. This is usually seen in females, common in the tail, multilocular, no duct connection. This is very, 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 very important. Since it is not connected with the duct, endoscopically you never see mucin at the ampulla, whereas in IPMN, they are connected with the duct system, so they will produce lot of ampullary mucin. Ovarian type of stroma is a must, and it can be associated with carcinomas. And whenever I have a table like this, I will remember the features of one of the lesion. So the opposite is for the other lesion. If you try to remember both, you will get confused. So I will try to know the features of mucinous cystic neoplasm or IPMN, not both. This is another characteristic lesion, and you can see there are two lesions here. And this is, if you have seen once in your lifetime, you won't forget. This is like a sponge-like pattern or sieve-like pattern, very, very classic of serous adenoma. And it can be, when it is multiple, you have to think of von Hippel-Lindau syndrome because it is associated with abnormality in the VHL gene. This is another lesion with a sieve-like pattern with a central scar. And this is how it will look microscopically. This is the adjacent pancreas, well circumscribed lesion, multiple cystic spaces lined by cuboidal cells with a clear to eosinophilic cytoplasm. And when you do with the PAS, they will have a lot of glycogen, PAS positive, PASD negative material. And if you do VHL gene, they will be positive. I will show the picture down the presentation. This is another cystic lesion known as acinar cystic transformation. Previously, it is called as acinar cell adenoma. That can also be multiple, and these are pancreatic duct. See how beautiful this gross image is. See one of the duct running here. Microscopically, this may, on the low power, this may look like a serous cystadenoma. But when you go to high power, you can see acinar type of cells as well as ductal type of cells that are seen best in the high power. These are ductal type of cells, whereas these are acinar type of cells. If you are in question, you can do double immunohistochemistry. The ductal cells are brown and they are positive with CK19, whereas the chymotrypsin is red and they are staining the acinar type of cells. So the acinar cystic transformation or cystic transformation of acini shows both the ductal and acinar type of cells with a lot of cystic spaces that can be connected with the ductal system.